Welcome to the State Health Registry of Iowa video training series on colon cancer. I'm Lori Summers, the trainer at the Iowa Cancer Registry. This presentation will cover the solid tumor rules for colon and rectal cancer. Here we are back at the anatomy. Remember that the primary site and histology pull up the correct schemas for staging. The codes for the primary site range for colon C18.0 through C18.7. So we've already looked at this anatomy in part 1 video. The illustrations in the solid tumor rule manual on page 66 also give you good pictures for reference. Like other primary site codes, there is a 0.8 code, a C18.8, not shown here, but used for a tumor that is large enough to overlap two subsites. For colon and rectum cancers, you probably won't use the 0.8 very often. There is also a C18.9 for colon NOS, or not other specified. Also, this shouldn't be used very often because if workup or surgery was done at your facility, you should usually have the details of the specific tumor location. Remember for 2018 cases and forward that the colon, rectosigmoid, and rectum are all now in one schema. In the SHRI manual coding guidelines, there is a document for coding the primary site for colon. It gives priority order for where to take the primary site from. If you go to the SHRI manual, it's page 95, item 8, and then it gives you a link to the coding guidelines for colon. For resected cases, the operative report with the surgeon's description should be used over the path report or imaging to determine the primary site. In general, don't rely on the path report label unless that's all you have, because remember, the surgeon is actually seeing where this tumor is located, and the path report label that goes on there is only as good as what was labeled in the operating room. Sometimes a path report might be labeled rectosigmoid, but don't automatically code the primary site to C19.9 for rectosigmoid. Sometimes if you look deeper into the op report, you will see the tumor mass was really located in the rectum, and the best coding of the primary site would be a C20.9. For cases where there's a polypectomy done, the endoscopic report would contain the best information to code the primary site location. Now, path report is listed on both of these. It's second. That doesn't mean you cannot take it from a path report, but just be careful when you're trying to find the primary site and really try to narrow it down and text that information well. Okay, so here's the guidance for coding the primary site in tumors which overlap colon subsites. Code the subsite with the most tumor if it can be determined, or code C18.8 when both subsites are equally involved. Like I said, you probably won't use the 0.8 code very often. Remember, when there's a lack of information, the colonoscopy measurements can be used as a last resort to determine the primary site. And there is a picture in the solid tumor rules for that. This diagram of the approximate colonoscopy measurements is found in the illustration section. Colonoscopy reports will describe the location of a mass or a polyp as being so many centimeters from the anal verge. This measurement can then give us an approximate location. So for example, if a mass is described as being 65 centimeters from the anal verge, the code would be to code that in the descending colon by using this diagram, since the descending colon ranges from 57 to 82 centimeters. Read carefully so that you know it is the location of the tumor and not the size of the tumor. The majority of colon and rectal abstracts will be straightforward and easy to code the primary site and histology. Since the majority of cases will have one primary, and the histology most likely will be adenocarcinoma. The NOS 8140 is the most common type of colorectal histology. However, there are some cases when more than one tumor is found in the large bowel, or a case where there is one colon mass along with multiple malignant polyps. So those would be examples of where you need to turn to the solid tumor rule manual to help you decide how many primaries you have and how to code the histology. Sometimes you will have one tumor, but you will have a complex histology. So the solid tumor rule manual will also give you guidance for that information. These are the sections in the manual. We'll start out in the introduction. There are a few changes listed from the old rules. There are equivalent and equal terms. Table 1 gives you the histologies, and Table 2 is very helpful with non-reportable terms. And like I mentioned, there's a section of illustrations. The introduction goes on to tell us that 98% of colon cancers are adenocarcinoma and subtypes of adenocarcinoma. If you have a mixed histology, it will be rare. Also, you can see the terms listed here for neuroendocrine tumor or carcinoma or the GIST tumors. GIST are difficult to determine the behavior. A lot of times the pathologist is unable to decide if they are malignant or benign. Effective for any 2018 diagnosis and later. Code the most specific histology from the biopsy or the resection. If there is a discrepancy between the two, code the most representative specimen or the greater amount of tumor histology. The term carcinoid is not going to be used as often. NET or neuroendocrine tumor is more likely what you will see. Those arising in the appendix are reportable starting in 2015 and forward. There is a histology pseudomyxoma peritoni. If it's high grade, it is malignant. If it's low grade, it is not malignant and not reportable. There are a list of terms. It's very helpful to familiarize yourself with the terminology that this manual is using, particularly for the colon cancer terms. And so if you just take a glance at that, that will help you also understand the rules. Dysplasia or a /2 is not reportable in the US for colon cancer. A lot of times on the path report, pathologists will use the term severe dysplasia or high-grade dysplasia instead of stating carcinoma in situ. We are only coding carcinoma in situ and reporting that if the pathologist states a CIS. If they do not use the term CIS, it is not reportable. I mentioned earlier that we are disregarding polyps when it comes to coding histology, and all of those now will be coded to 8140 if it's an adenocarcinoma in a polyp. Table 1 gives the list of specific histologies, the NOS and subtype variants. Rare histologies may not be listed in this table. If there's a code specific to a behavior of a /2, which would be non-invasive, or a /3, which would be invasive, it means there's only one possible behavior for that specific histology. If it does not specify, then it could be either a behavior 2 or a 3. And we hear a lot in the webinars that we do to get familiar with the columns and the rows in each of these tables, because it's very helpful to know if you are on the same row or you have moved to a separate row. And when there's a page break, sometimes that's difficult to determine. Here's a glance at Table 2 with the non-reportable codes and terms. There are actually 4 pages of non-reportable terms. If you look at the bottom of this slide, it does talk about dysplasia or high-grade dysplasia currently not being reportable. And so this table is very helpful when you have terms that maybe you don't see very often. Go ahead and take a look and see if it's listed on the not reportable Table 2. When we move into the actual multiple primary rules, you will have 3 headers that you need to choose from. Either you don't know that if it's single or multiple. The next header would be if you have a single tumor, and then the next header would be if you have multiple tumors. You can jump to any of these headers, but once you start in those rules, so say you had a single tumor, but you had a circumstance where you need to go through the rules, then start at M2, but work your way through the rules and stop when that applies to your case. The easiest way to understand these solid tumor rules is to just look at some examples. So we'll first start with some examples which relate to the multiple primary coding. Example 1 is a case where there are 2 masses found at the same time. One cancer is in the transverse colon, and another mass is found in the descending colon. So first we need to decide how many primaries we will abstract. And because of the new rules, we know that we need some preliminary histology in order to decide if we have more than one primary or not. So the first thing I do when I have cases like this is I pencil in and I get my working primary sites and I get my working histology. Both of the biopsies in both of these locations in the colon ended up being adenocarcinoma, so 8140 for both lesions. And then it helps to pencil in your primary site for transverse would be C18.4. Primary site for descending colon would be C18.6. So from there, we can go to the multiple primary rules and see if we have more than one abstract. One other note on the primary site codes, as you go through the rules, the C is counted as the first digit. So your primary site code, they consider having 4 digits, C18.4, not counting the decimal. Starting in the solid tumor rules at the multiple tumor header, which would be rule M3, we walk through these rules. Obviously, we don't have polyposis, so that doesn't apply. Looking at M4, it tells us to look at our primary site codes and do they differ at the second or the third character. Our second and third character are the same, so we're not going to stop yet. So we need to keep going. We do get to M9. So rules M5 through M8 do not apply. M5 and 6 have to do with different histologies. M7 and 8 have to do with the anastomotic site recurrence, and we don't have any of those. So we stop at rule M9. It's asking if we have difference in the fourth character of the primary site. Remember that the whole point of the solid tumor rules and the multiple tumor rules are to give us a consistent and standardized coding system so that we are consistent with our incidence and that we aren't counting tumors too many times or not enough. M9 fits our case. If you look at the C18.4 and C18.6, that fourth character is different. And so this tells us that this is a multiple primary. So then each of these would be separated out and you would make one abstract with a C18.4 and another abstract with the C18.6. We already know they were both adenocarcinoma, so then the histology is simple. You just code those to 8140. All right, example 2. This would be a comparing a historical cancer with a newly diagnosed cancer. On page 1 of the colon introduction, it does explain that if you have an original tumor diagnosed prior to 2018 and a subsequent tumor diagnosed 2018 or later in the same primary site, use the 2018 solid tumor rules. So that's what we will do. In this case, we have a colon cancer diagnosed in 2000, already abstracted, probably already on your database. Primary site is C18.2, and the histology is invasive adenocarcinoma. Then in 2018, the patient is found to have a recurrence at the anastomotic site, diagnosed exactly as mucinous adenocarcinoma 8480. So I've penciled in just a working histology for the 8480, and your database is already telling you what that original 2000 diagnosis was. There is a rule that addresses recurrence at the anastomotic site. I kind of remember that from going through the rules. So we will start again at the multiple primary header, and we will go through starting at M3, I believe, and then following through to M7, which does apply to our case. M7 relates to the tumor that arises in the anastomotic site. Our tumor arose greater than 24 months after the initial tumor, so it is a multiple primary. So rule M7 says abstract multiple primaries when a subsequent tumor arises at the anastomotic site and the subsequent tumor occurs greater than 24 months after the original tumor resection. It just so happens that this case, our case, also one tumor is an NOS, the adenocarcinoma, and mucinous is not a subtype variant of the adenocarcinoma. So that's why we drop down and use the timing rule on this one. So what would happen then, your original cancer in your database would be your sequence 01, and then this anastomotic recurrence would become tumor 02, sequence 02. It doesn't matter if the physician is calling this recurrence. Note 1 says there may or may not be physician documentation of anastomotic recurrence, but we follow the rules so that we are consistent, again, with our incidents and our reporting. Okay, so moving on to the histology rules for colon, rectum, and rectosigmoid. The priority order for using the documentation to identify the histology is listed here. Do code the histology prior to neoadjuvant treatment. Do code the histology assigned by a physician or pathologist. Do not change the pathology or the morphology in order to stage a case. And what happens is sometimes you have a histology that's not listed in the chapter for AJCC, and so you cannot change or tweak that in order for you to be able to stage the case. Also, we want to code the most specific pathology or tissue from the resection or the biopsy. The most specific would be a subtype or a variant of that NOS. We're always going to code the invasive if you have both an in situ and invasive. Again, if there's a discrepancy between the biopsy and the resection, code from the most representative specimen or the greater amount of tumor. Always look at not only the path report, but any addendums, a final path, your CAP summary. You can take histology from a metastatic site if that's all you have. And it seems strange to take a histology from a scan or clinically or cytology. But what that's saying is if you have a diagnosis in a report that is saying consistent with colorectal adenocarcinoma or consistent with rectal carcinoma, that you can take that if you don't have anything else. So for multiple histologies, you're going to code the histology when the exact term is documented, like mucinous, or you're going to code the histology described as subtype, type, or variant. Remember, do not use histology rules from other primary sites. Do not cross-contaminate these rules. So if you're coding a colon cancer, forget what it says in the breast rules for histology. We're not gonna, those do not overlap. We've kind of covered this. Code the most specific, code the subtype variant. If there's a code that is described as differentiation or features of, you can only code that histology if there's a specific code that states features of or differentiation in the name of the histology. And there are a couple of those on table 1. Okay, so coding specific histology described by ambiguous terminology. A or B listed here has to be true. So the only diagnosis available is described by ambiguous terms. You would accession the case because that's all you have. Or if you have an NOS and a more specific describing the ambiguous terms, you can only use that ambiguous specific histology if it's confirmed by a doctor or the patient is receiving treatment based on that specific histology. And the physician would have to state that. We wouldn't know that. Do not code histology described as architecture, foci, focus, focal, or pattern. So we are ignoring those words for 2018 and forward. So it's easier just to look at the histology rules in the manual. Again, we have the headers. So if you have a single tumor and you're looking to see how to code the histology, start under the correct header, and we'll start at H1 and then just follow down the rules. So here's a good example in H1 when the final diagnosis is exactly adenocarcinoma with neuroendocrine differentiation. It has to be stated that way in order to be able to use that term differentiation. H2 talks about histology and the polyp. H3 is giving us direction if we have a combination code, if we have small cell and any other carcinoma. H4 is when you have mixed mucinous and signet ring cell. And then if you know the percentage. So again, think about what you're texting as you're looking through your path report. You're going to need to know if the mucinous is documented as greater than 50%, you'll code it to mucinous. If the signet ring cell is documented greater than 50%, you'll code it to signet ring cell. So as you're looking through your rules for histology, it will really help you to define what you need to be looking for and also what you're texting. H5 is for when you have a mucinous or an exactly mucinous adenocarcinoma. There's no modifiers. There's no combination. And then the rules go on. If you have an adenocarcinoma, if you have the percent, if you don't know the percentages, or if it's less than 50%, you will go back and code it to the NOS. So very specific direction. And then obviously, if you just have one histology, code that histology using table 1. And there's the rule 8, code the invasive if you have both in situ and invasive in the same tumor. Rule H9 is when you have an NOS and a single subtype variant of that NOS. So that's where table 1 comes into play, where you need to know your rows because the single subtype variant for that NOS will be on the same row. Okay, starting with rule H10, you can see our header has changed to multiple tumors abstracted as a single primary. So how would you know that? Well, you always start with the M rules, the multiple primary rules, figure out how many tumors you have, and then you go to the H rules. So if the M rules have told you, even though you have multiple tumors, you're going to abstract that as a single primary, then here's your rule H10 that explains what histology you're going to give that tumor. And then it goes on. A lot of these are the familial polyposis rules, but you might have 2 tumors that are invasive and in situ, which H12 is just covering that again. And then code the histology when only one histology is present in all the tumors. Then it's telling you you can take that one histology and go to table 1. One other thing with the tables, you can go to the table to get like a preliminary histology, but don't settle there. You still need to go through the rules and then only go back to the table when the rules tell you to go back to the table. And there's a link when it does tell you, and you can link right to that. H14 ends the multiple tumors abstracted as a single primary. And again, this is talking about When you have an NOS and a single subtype variant of that NOS, then you would code the subtype variant. A lot of these cases is going to fall out before this, but if you have this case, you have multiple abstracted as a single primary, this rule is in here again to fit that scenario. Okay, just a word about the NET or the neuroendocrine tumors, the carcinoid terminology. You're probably, hopefully not going to be seeing too much, but these schemas all start alphabetically with NET. So they do have different schemas. All of the NET tumors are considered malignant unless they say they are benign. I think I mentioned appendix carcinoid or NET of the appendix is reportable. And just keep it simple. Most of these are a behavior invasive unless it's designated that they are benign. The FAP that we looked at, some of the histology rules, is referring to this disease, the familial adenomatous polyposis. This is a genetic defect, and these people have over 100 colon polyps. Most of them are tubular adenomas, but they do progress 100% to colon cancer. This is reportable only when there's cancer in a polyp. So if they've done a biopsy and they say FAP, that's not reportable until you actually have proven cancer. And it's rule M3. These are single primaries. It doesn't matter how far through the bowel these are. It's just that genetic condition. And then rule H10 gives you the histology that it is a specific histology for these. Even though the anus has its own schema ID, it does not have solid tumor rules. We would then use the 2007 MPH rules if you have an anus primary site. To find these primary sites, go to your ICD-03 Purple Book, and they will be listed out. Even though it's a different schema, I just wanted to cover this. The primary site location of the anal canal, so the anus, the anal canal, the cloacogenic zone, and then you see that 0.8, that overlapping if there's a tumor big enough to overlap these areas. Squamous cell carcinoma, the 8070, will arise in the anus since this area is lined by squamous epithelium. Also, there's a type of transitional cell carcinoma called cloacogenic, and that will arise at the anal rectal junction, and that has its own histology code of 8124. And so the appropriate code for that would be a C21.2. So this is in a different schema, but there are no solid tumor rules for this. So you would, again, use the old 2007 MPH rules if you had numerous tumors or numerous histologies and you needed to figure out how to code this. Let's do one histology example. So this is a path report from a left colon resection. Its final diagnosis is MOD-DIF adenocarcinoma. Remember that the rules tell us to take the primary site first from the op report and then the path report. However, all we have is a path report, and it does state that it was in the splenic flexure. So we can code this to C18.5. And this is an example of a single tumor. So we do need to go to the H rules to see how to code the histology. And remember, the priority order for identifying histology is coding it from the path report. So under the header for single tumor, we would start at H1 and read through the rules and stop when the rules apply to this case. So H5 for histology applies to this case. We will code the invasive mucinous adenocarcinoma 8480 when the diagnosis is exactly mucinous and there are no modifiers. So for this slide, the primary site would be C18.5. The histology and the behavior would be 8480/3. Following this section, there are 5 exercises, and we will take time to go through these. You can pause the video at this point. You have the exercises on your PowerPoint if you want to work through those. And when you're ready, you can click play, and then I will go through each of the exercises when you're ready. Case 1, this is a sigmoid resection. So that kind of gives you a little bit of a hint of where the tumor is. We don't have an op report. All we have is a path report. And it was a poorly diff adenocarcinoma with mucinous features. And then gives us a little bit of information about the invasion and the lymph nodes. So based on the information that we know here, the best information we have is that this is a sigmoid primary, so C18.7. The adenocarcinoma with mucinous features. We have a single tumor, so we start in that header and work our way down through the rules. Rule H6 says to code the adenocarcinoma NOS 8140 when the final diagnosis is 2 histologies, so we have adeno and we have mucinous, and the percent of mucinous is not known. And also remember, we ignore the term features. So we are going to code this to adenocarcinoma 8140/3. And there's the rule. Okay, going on to case 2. This is a single tumor in the left colon. So the histology is not so simple on this one. We need to go to the histology rules to decide on the histology code. The primary site, we know from the path report, it simply says left colon. We don't have anything more specific than that. So the primary site would be C18.6. Now we go to our histology rules, and we have one tumor, we have a single tumor, but we need to figure out what the histology would be. We have an adenocarcinoma and we have a signet ring cell carcinoma. The rule H9 applies because signet ring cell carcinoma is a subtype variant of adenocarcinoma. Rule H9 says code the subtype variant when there is an NOS, the adenocarcinoma, and a single subtype variant of that NOS, such as adenocarcinoma or a subtype of that. And so we went to table 1. Signet ring cell is listed as a subtype variant of adenocarcinoma. So 8490/3, and it's based on rule H9. Okay, case number 3. This was a colonoscopy, and there was a tumor found. The biopsy showed that they resected part of this rectal mass, and it showed dysplasia, high-grade intraepithelial neoplasia. And so this would be a good time to go to Table 2 and see if this is something that maybe is not reportable. And according to Table 2, this would not be reportable in the US. We do not have a term in our path report that says carcinoma in situ, or CIS. So this would be not reportable. And let's look at Table 2, that area where the non-reportable terms are. And our case said dysplasia, high-grade intraepithelial neoplasia. So in the red box here on the slide, you can see that that is currently not reportable. Moving on to case 4, so this case had an adenoma in the hepatic flexure. And then, and that was from the op report. And then in the final path, the adenoma did have mucinous adenocarcinoma with invasion in it. So under Rule H2, we're going to ignore the polyp and the adenoma. And we need to figure out what else we have in this case. So first, we know that it's in the hepatic flexure. So that would be a C18.3. We also have a statement of mucinous adenocarcinoma. We've looked at that rule before, the H5. We have exactly mucinous adenocarcinoma. And so that would be the 8480/3 based on Rule H5. So you can see sometimes with these single tumors, it's not hard to figure out the primary site, but a lot of times we need to figure out what the histology will be, and you can go straight to the H rules or the histology rules to do that if you have a single tumor. Okay, case 5. We have a surgery or an op note that there was a right hemicolectomy. They also palpated the liver, and that was normal. In the final path report, we actually have 2 tumors. The ascending colon has a 3.7 centimeter tumor. The hepatic flexure has a smaller 0.9 centimeter polyp, but there is invasion in there. So up at the top of the path report, it says both of the histologies of the 2 separate lesions are all ma-diff adenocarcinoma. So we can actually pencil in adenocarcinoma for both of these tumors. We know they're both the same histology. One of them is in the ascending colon, one is in the hepatic flexure. So let's look at how many primaries we have before we decide how to code these and figure out how many abstracts we have. So first we'll go to the multiple primary rules, start at M3 under the header for multiple tumors, work your way down through the M rules and stop at M9. Both tumors are the same histology, but they are in different sub-segments. So, we could have gone back and actually penciled in ascending colon would be the C18.2, hepatic flexure would be C18.3. So we know that fourth digit is going to be different. If none of the other rules pull us out, we know we get to M9 and this will be 2 abstracts. So our primary sites then would be the C18.2, the C18.3. M9 is abstract multiple primaries when the sites differ at the fourth character. And then the histology behavior is going to be the same histology for both tumors because there's nothing else mentioned in the path report. They're both adenocarcinoma. And there's the M9 rule. There are exercises on SEER Educate. For the solid tumor rules, there are 5 cases for the colon and rectum that are helpful just practicing and getting some confidence in reading the rules. The best advice I have for you is assigning a working primary site, assigning a working histology, go to the rules. It helps to know what you have when you're starting to go through the rules. And then also familiarize yourself with the columns and the rows on table 1, knowing which NOS and which column is the subsite of that same disease, because that's what you're going to need to know when you go through the multiple primary and histology rules. If you have any questions, feel free to contact me. Thanks for listening.